Alzheimer's disease is a type of dementia. The term dementia here is an indicative of cognitive decline, difficulty doing daily activities, and there's also a gradual decline in psychiatric and behavioral awareness. The primary reason is that there is an acetylcholine deficiency in the nucleus of the Maynard bacillia. Where is that, you may ask? So let's say this part is the amygdala, the emotion part, and running behind it is the hippocampus. The nucleus of the Maynard bacillia is right above that and is a large source of cholinergic innervation that spreads to the cortical areas of the brain. Degeneration in acetylcholine, specifically in such a rich acetylcholine area, would cause dementia-related symptoms. Alzheimer's disease commonly occurs with patients that have a chromosomal defect in 1, 14, 19, and 21. Chromosome 21, famous for trisomy 21, or Down syndrome, is prone to Alzheimer's due to the overexpression of the APP gene. Chromosome 19 has an overexpression of the ApoE4 gene. Do not confuse this with the ApoE2 and E3, as they are not related with the pathogenesis of Alzheimer's. So pathologically, what happens is that in these normal neuron cells, the cytoplasms end up having a neurofibrillary tangle, these aggregated hyperphosphorylated protein that are found intracellularly, and extraneurally there are amyloid plaques. Now, when we say amyloid plaques, alpha-beta amyloid can be found due to the aging and has nothing to do with dementia. But alpha-beta 2 amyloid is very much related to the development of dialysis dementia. So the two things that are significant to Alzheimer's is the neurofibrillary tangles, and they're proportional to the dementia severity, and the alpha-beta 2 amyloids. The clinical features of Alzheimer's can be remembered with the 5 A's. The first one is amnesia, memory loss, that initially is short-term, like, oh, I forgot my keys, or where did I put my glasses? And it progresses into a long-term syndrome, in which the most common one is that people forget their way back home after stepping out. The next is aphasia. This is basically having a problem understanding words. People with aphasia have a hard time finding the words they need to express themselves, and sometimes they might find it hard to understand what people are saying. Apraxia is also a form of inability to communicate, but in this case it's that the person has a hard time coordinating the muscle movements to produce the right sound for proper speech. So they may understand you, but they're unable to reply. Agnoxia is the loss of ability to recognize things, places, voices, and faces. So it's like the lack of awareness. And the last one is anomia, which is a form of aphasia where the patient can't recall everyday objects, specifically unable to recall words. So in this very simple brain diagram, here would be the temporal lobe in charge of memory, and so a good portion of this is affected in Alzheimer's. The parietal lobe, right above the temporal, is in charge of language, and this too is affected, and this damage here is what causes the symptoms of aphasia and apraxia. The frontal lobe features may seem like it should be affected, and there is a separate diagnosis known as frontal lobe dementia. In Alzheimer's, it usually occurs late into the disease progression. So the main lobes that are affected in Alzheimer's are the temporal and the parietal lobes. So when you suspect a patient has Alzheimer's disease, you first do a screening test, and the most popular one is called the MMSE, a mini mental state exam. So this test includes simple questions and problems in a number of areas, such as repeating lists of words, language use and comprehension, and basic motor skills. One of the questions is to draw 2 pentagons, and this is because Alzheimer's patients are known to have a hard time drawing geometric shapes. So these are scored out of 30. Less than 24 to 30 is dementia. If you have a score of 21 to 24, it's mild, 10 to 20 is moderate, and less than 10 means that the patient has severe dementia. Now the treatment of choice here is to do an MRI. Here's a scan of a normal MRI versus an MRI of Alzheimer's disease. Immediately you can see that the ventriculars look relatively larger. There's also less folds and less numbers of gyri and sulci in the deceased MRI. And the next most immediate thing is that there is a reduction of gray matter. All of these features are due to the atrophy of the brain, and it almost looks like there's an hydrocephalus-like presentation and a pseudo-enlargement of ventricles. There are multiple differential diagnoses for Alzheimer's disease based off of the MRI and the screening test. The first one, like we mentioned earlier, is hydroencephalus. This type of dementia is reversible. You also have vascular dementia, and this usually occurs in a setting of a recent stroke that occurs in the significant vasculature of the brain. Another differential is the Kruetzfeldt-Jakob disease. And this is essentially a rapidly progressive dementia and presents with a specific type of protein in the cerebral spinal fluid, so you can actually do a tap and test for it. Another differential would be dementia with Lewy bodies, and this will be spoken more in detail in the Dementia chapter. And the last one is frontotemporal dementia, and we mentioned it earlier when we were going through the brain diagram. And this can be differentiated based off of the behavioral aspects of the patient. So in questions, if you get a patient with dementia and chorea, then suspect Huntington's chorea. Depression can also manifest as a pseudodementia and is entirely reversible. Beta-12 deficiency and hypothyroidism in some extents do cause reversible dementia. And we're mentioning it again, hydroencephalus also causes reversible dementia. So treatment for this, because it is related to acetylcholine deficiency, you would want to give a cholinesterase inhibitor, which essentially prevents the breakdown and decrease of corticoacetylcholine. So the common medications would be donepezil, rivastigmine, and galantamine. Donepezil is the drug of choice that's usually given. The other drug, a relatively new one, is called memantine, which is a NMDA receptor antagonist, and this is usually used in moderate to severe Alzheimer's disease. If the patient has really aggressive Alzheimer's disease, then you can also consider using a low-dose antipsychotic. And that's the end of the Alzheimer's discussion. Thank you for watching.